Hello, everyone. This is Aubrey Villalobos from GW Cancer Center. I would like to welcome you today to this webinar and say thank you very much for taking time out of your afternoon to spend with us to learn about this important topic. This webinar is called Eliminating the Hepatitis B virus and Hepatitis C virus to Reduce New Cases of Liver Cancer. I would like to welcome our CDC presenters, Dr. Blythe Ryerson and Dr. Banush Momin. I will introduce them formally in just a moment. I would also like to acknowledge CDC, who has been a wonderful partner in this process. They provide us a cooperative agreement to deliver technical assistance to comprehensive cancer control programs and coalitions across the country. And the project today that we're going to be talking about was also sponsored by the Division of Viral Hepatitis. So this was a wonderful collaboration between the Cancer Control Branch and Viral Hepatitis at CDC. I would also like to thank Kaneko Kashima. She is a former staff member here at GW, and she developed these slides and the concept for the materials we're going to be sharing with you today, so we thank her for that. Danielle Agraviador and Ria Suarez are helping on the back end of the webinar today, so I thank them. And I thank D'Angela Green and Annette Gardner from CDC, who helped us work through the clearance process to bring all of these materials to you. A couple of housekeeping matters. If hopefully you have clear audio coming through now. If you have any issues, please feel free to use the chat or question and answer feature, and Ria or Danielle will address your concerns. You are welcome to use the chat feature to talk with each other, share resources, links, engage with each other, or you can submit private questions to the hosts if you have a question to share. We'd like to start off the webinar just with a couple of quick polls. Ria will be pulling up the first poll for you. We're curious to know what populations you work with the most. So if you could just please take a second to answer this question, that will help us have a sense of who is on the webinar with us today.
Okay, the poll is now closed and the results should be shown on your screen.
Yes, thank you. Okay, so it looks like we have a good diversity of folks on the call today. Maybe a majority work with people who inject drugs and minority groups. A good number work with older adults, with pregnant women and newborns and foreign-born individuals. So a good variety of you on. Thank you for joining us. We have one more poll. The second poll, we're curious to know if your program or a coalition you're involved with is currently engaged in any liver cancer or viral hepatitis control activities. So go ahead and take a moment to answer this poll, and then we'll see how many of you are already working in this space and how many may be new to this space.
Great, thank you. The poll is now complete.
Okay, so we have 37 of you are already engaged in liver cancer or viral hepatitis control efforts. But it looks like we have a number of participants on who are not currently engaged in these activities, and so we want to welcome you. And we are very excited that you have decided to join us. So let's review the learning objectives for today. What we're hoping is that after these 90 minutes together, you will have a better understanding of what the CDC's Division of Viral Hepatitis and Division of Cancer Prevention and Control and the Comprehensive Cancer Control Branch are doing around liver cancer and viral hepatitis. We hope that you will be able to relay strategies and key interventions to eliminate new viral hepatitis B and C infections and reduce the risk of liver cancers to others. We are going to be providing slides for you, and we hope that you will share this information when you go back to your local coalition or task force. We hope that you can describe the connection between these viruses and liver cancer and name the at-risk populations. List key interventions outlined in the National Academies of Sciences, Engineering, and Medicine report. and locate technical assistance resources and partner organizations in order to implement some of these strategies. So I'm going to introduce our speakers now. Our first speaker is Blythe Ryerson. Blythe is the Associate Director of Science for CDC's Division of Viral Hepatitis. She is responsible for assisting the Division Director in shaping and implementing the scientific vision and mission of viral hepatitis research and public health programs at CDC. Dr. Ryerson received her doctorate in epidemiology from Emory University in Atlanta. She joined CDC as a cancer epidemiologist in 2001, spending most of her tenure conducting cancer epidemiology and surveillance research, including examining the association of hepatocellular carcinoma and viral hepatitis. She joined the Division of Viral Hepatitis in 2016. Our second speaker is Banush Momin. Banush is a health scientist in CDC's Division of Cancer Prevention and Control's Comprehensive Cancer Control Branch. She currently provides scientific expertise to a wide range of the division's research studies. Dr. Momin's research focus is in liver cancer prevention and its risk factors. She currently leads a collaborative study with CDC's Division of Viral Hepatitis, which involves the development and implementation of an evidence-based action plan for liver cancer prevention. Additionally, Dr. Momin is actively engaged in research related to tobacco-related cancers. Dr. Momin is the co-founder of CDC's Tobacco-Related Cancers Work Group, which promotes tobacco-related cancer epidemiological research, education, and awareness to decrease cancer incidence, morbidity, and mortality. And I'm also one of your presenters today. I am the Director for Cancer Control and Health Equity here at GW Cancer Center, and I oversee our technical assistance project for the CDC. And I will be sharing some of the strategies from the National Academies report and suggested resources and partners towards the end of the talk. But first, we're going to hear from Dr. Ryerson. So I will pass her the ball, and she will now take over with her presentation. Dr. Ryerson?
Yes, hi. Aubrey, can you hear me okay?
Yes, ma'am.
Excellent. Okay. Good afternoon, everyone. I'm pleased to be here. I'm going to be presenting a very broad overview of viral hepatitis. So for our viral hepatitis partners on the call, it'll be a review of pretty basic information, but for those who are not as familiar with hepatitis, I think it'll be helpful to understand. I'll go into specifics about hepatitis C virus and hepatitis B virus, which are the chronic infections mostly related to liver cancer. I'll talk about their role in developing liver cancer, and then I want to just very broadly touch on what our Division of Viral Hepatitis is doing here at CDC. Okay, so first, just a quick review of what viral hepatitis is. The term hepatitis is a broad term that really defines any inflammation of the liver, and there could be multiple causes of hepatitis. Alcohol can cause hepatitis, certain drugs and toxins, even some nutritional supplements can cause inflammation of the liver. But of course today we're focused primarily on the viruses that cause hepatitis. There are actually 5 distinct viruses that cause hepatitis, and we name them A through E. Hepatitis D and E are uncommon in the United States. Hepatitis A is also uncommon. It causes acute infection, though many of you may have heard media reports of an ongoing multi-state hepatitis A outbreak. And this is concerning. It's been documented in people who report homelessness and drug use. And so, again, it results in just acute infections, but there have been high hospitalization rates and death rates, primarily due to the comorbidities and the vulnerability of these populations. But today's talk is really focused on hepatitis B and C because these result in chronic infections and can cause liver cancer. So just to make the distinction between acute and chronic infections are what happens first for hepatitis B and C. For hepatitis B, you can clear the infection or go on to develop chronic infection, but once you are infected, even if you clear it, you are immune, so you can't be reinfected. It's different for hepatitis C, where you can either clear the infection or be treated and then be reinfected. And I'll talk about the vaccine for hepatitis B in a moment. But both hepatitis B and C viruses can result in chronic infections, and these are long-term illnesses that there are treatments for hepatitis B. It's supportive therapy. Many people are just watched, and there are some antiviral medications that they can take that can help prevent further liver damage or cancer. For hepatitis C, there is a cure, and I'll talk about that in just a minute. So first, a little more about hepatitis B virus. It's primarily a bloodborne pathogen that can be also transmitted through semen. So the primary transmission routes are injection drug use or inadvertent needle sticks from an infected person. Infants can also be infected when born to a mother who has hepatitis B. And so these, and there are other means, but they're not as effective transmission routes. There is an effective vaccine, as I mentioned, and this is fantastic, and it has helped keep new infections at bay. The vaccine, I think the National Academies report states that 95% of hepatitis B virus infections can be prevented from the vaccine, but I think vaccination rates are still suboptimal, even among infants who are routinely vaccinated. The vaccination rate is really hovering only around about 72%, so we could be doing a better job. The ACIP recommends that all infants, of course, get vaccinated at first before they leave the hospital, and then they need to complete their vaccination series by no later than 18 months. Children under 19 who don't get the birth dose should be vaccinated, and then adults who are at increased risk for infection should be vaccinated, and that includes, of course, people who inject drugs, people who are incarcerated, men who have sex with men, and household contacts or sexual partners of people who are HPV positive. And then, as with all adults, pregnant women in particular who are at high risk should be vaccinated to prevent transmission to their infant. Acute hepatitis B infections have been pretty steady of late. I think they've been kept down primarily because of the widespread use of the hepatitis B vaccine, at least in the younger populations, though it's estimated that between 1 and 2 million people in 2012 had chronic hepatitis B, so it's still quite a significant burden in the United States. And I do want to point out that our surveillance data here at CDC, these acute hepatitis B infections are what's reported to CDC, and we know that they're largely underreported. So this approximately 3,000 new cases that were reported in 2016 actually represent, we think, at least 20,000 new infections. Here you can see the breakdown by age, race, and sex. Males have 1.5 times higher rate of new hepatitis B infections, and people aged 30 to 49 or 59 have the highest rates of new infections. Certain groups are at increased risk for having chronic hepatitis B, and this includes people born in Asia, Africa, and other regions with moderate or high hepatitis B, unvaccinated people from certain regions. But the key is that we need to identify the people at highest risk of these chronic infections and get them into treatment so that we can prevent, again, these long-term health outcomes, liver disease and liver cancer. So moving on to hepatitis C virus, it's quite distinct from hepatitis B. Transmission is similar again, bloodborne. Injection drug use is the biggest risk factor. Before the virus was identified and we really started screening the blood supply in the United States, many people did get infected, unfortunately, through receipt of certain blood products and organs. There's also, of course, risk for needle stick injuries in healthcare settings, and when there's inadequate infection control in healthcare settings. And then, similar to hepatitis B, birth to an HCV-infected mother is quite a risk factor for infants. So I created this slide because I think with any chronic disease, whether it's cancer or an infectious disease, I think it's quite a complex epidemiology. When you start talking incidence and prevalence and mortality, it gets kind of complex. And so I just wanted to illustrate what all these mean. But with hepatitis C in particular, we have this large pool of, and to a degree hepatitis B, this large pool of chronically infected people. And some of them are dying related to their hepatitis. Some are dying because they're aging and dying of other things. And so that pool can go down due to deaths. The pool can also go down due to treatment. As I mentioned, there's a cure that I'll talk a little bit more about in a second. So we might be siphoning off people as we treat them. But what's really worrisome is these increase in new cases that we're seeing. And so we've essentially turned the faucet onto high. We have this really high water pressure adding to the pool. So while we're making progress with treatment, we're also kind of increasing that pool of chronic or potentially chronic infection. So this is that faucet, kind of what I'm trying to describe. These are the new cases of hepatitis C reported to CDC, and again, they're largely reported. This 3,000 reported in 2016 really represents over 40,000 people. But since 2005, since 2005, we've seen a 3.5-fold increase in the number of cases, and it's largely attributed to the opioid crisis and injection drug use. And in 2010, we estimated that 3.5 million had chronic hepatitis C. This illustrates, I think, the concerning opioid crisis, really. If you look at the age groups, it's the 20 to 39-year-olds whose rates are increasing the fastest. So quite concerning, especially when we start, and we know that the rate of perinatal transmission has increased, I think, by like 68%. So even young women of childbearing age are at an increased risk, and so we might see an increase in the perinatal transmissions. And the American Indian Alaska Natives have the highest rates, followed by white non-Hispanics. This is no secret, the opioid epidemic is really wreaking havoc on our country. Seen increase in opioid-related deaths, and it's been really in kind of 3 separate waves. It started with the natural and semi-synthetic opioids, followed by an increase in heroin use, and now we're seeing this uptick in synthetic opiates such as fentanyl. And when we start to look at the relationship between the opioid crisis and hepatitis C, we start to see trends. I mean, we can't make a one-to-one relationship here, but you can see areas with high overdose death rates are also seeing high rates in new reported HCV infections. So bottom line is, there are many things we can do to prevent HCV, but really these primary prevention services are going to be key to really stop that faucet, and so that we can make more progress with the chronic hepatitis C infections that exist today. And this, there are evidence-based interventions, syringe service programs, so access to these safe injection equipment and drug addiction treatment can lower transmission by over 70%. But if you look at this map, it's quite concerning in that the little triangles show the syringe service programs that were available in 2015 and 2016 are really not always in the areas of highest need. The red dots are the new HCV incidents, I think, among young people. So need to expand access to these really life-saving treatments, or interventions, rather. But the one really good thing, with HCV, we don't have a vaccine, but we have really effective treatments. Gone are the days of interferon and really long treatment regimens with lots of side effects. Right now, the treatment, it consists of 8 to 12 weeks of all oral therapies, so just pills that are really well tolerated, that cure. We get sustained virologic response in over 95% of people treated. The initial price tag was quite high, but they've come down. The newest medications are around $26,000, which seems high, but when you start to think of if we were to wait until these people were diagnosed with liver cancer, the treatment for liver cancer is going to be much higher than that. So not only is the primary prevention important, but we need to screen those chronic infections that exist already today. So CDC recommends that everyone born between 1945 and 1965 get a one-time screen, and this is in part because I mentioned not having screened the blood supply and having different infection control practices many years ago, and to help reduce the stigma of any previous or current drug use. But this group is recommended to have at least one test, and then we also recommend anyone at high risk get screened. And so this is going to include, of course, any current or former injection drug users, whether they are in the baby boomer cohort or not, and certain hemodialysis patients, or any, of course, infant born to an HCV-positive mother. So how is this all related to liver cancer? Well, I want to start with kind of defining how our national cancer surveillance system lumps cancers together typically. So liver and bile duct cancer are grouped together usually, and when we're referring to them, we're really talking about primary liver cancer, so those that start in the liver, because the liver is a common metastatic site, and so we're not considering any cases of cancer that may have metastasized to the liver. But hepatocellular carcinoma, or HCC, is the most common type of liver cancer, and it can be associated with viral hepatitis, but is not always. What causes HCC? Of course, we're here today because HBV, chronic, and chronic HCV cause it, but also alcohol use, liver cirrhosis, diabetes. Obesity is a very important one for our country because it's so prevalent. And then there are some rare metabolic conditions that can cause it. So here's some cancer incidence data from the United States Cancer Statistics, or our National Program of Cancer Registries and SEER programs combined. These are age-adjusted rates. You can see that all types of cancer rates are going down, which is great news for our nation. Unfortunately, there are just a couple specific cancer types that are going up. One of those is liver cancer. But please note the difference in the y-axis here. Liver cancer is still relatively rare. And here I added it in for our state partners. I'm not sure I have much to say about it, but these are the age-adjusted rates by state. So they don't necessarily match up with our new incident cases, because these are not, the liver cancers are going to be more parallel with chronic infections that exist in our country today. So because of the increased rate of liver cancer going up, CDC, in collaboration with the National Cancer Institute and the American Cancer Society and the North American Association of Cancer Registries, each year publish a national annual report to the nation on the status of cancer. And so in 2016, CDC led that year's report and wanted to make a focus on liver cancer because of the increasing incidence, but also because it's really has such public health implications for our partners, whether it's through the CCC programs that many of you work in, or things that our prevention coordinators in viral hepatitis can work on. You know, there are interventions that can prevent new cases of viral hepatitis and ultimately prevent many cases of HCC. So this comes directly from the annual report to the nation. It just shows how this baby boomer group that I discussed, the people born 1945 to 65, have higher rates of liver cancer, really likely due to these increases in hepatitis infection. And this shows HCV-related liver cancer deaths. Again, the same concept. The baby boomer group who has the highest rates of chronic infections right now are dying at higher rates for HCV-related deaths. And definitely don't want to leave out the importance of HBV, but this is a study from Taiwan that shows that the cohort that started receiving and benefiting from the vaccine have much lower rates of both hepatocellular carcinoma and deaths, so that both incidence and deaths. So very important to continue vaccinating. So what do we do at CDC in our Division of Viral Hepatitis? You know, we're a small division, but mighty, I would say, with limited resources. I think we do quite a bit. And we have a number of, we have an HHS National Viral Hepatitis Action Plan that we work within. We have our own plans, of course, and are doing what we can to combat this problem. So within surveillance and research, of course, we have a surveillance system. Viral hepatitis is a reportable disease and is reported voluntarily to the National Disease Surveillance System at CDC, and we also, in the Viral Hepatitis Division, fund additional sites. We fund 14 sites to really do an enhanced surveillance system where they focus on complete reporting and also getting risk factor data from the reports that come in. We also do many modeling projects. So we use existing data sets, whether it's Medicare or Medicaid data, other CMS data, or laboratory data, to try to model, you know, small area estimates, and we do lots of prevention research and intervention research. We also, of course, I think what is one of CDC's strong suits and missions, of course, is to build state and local and tribal capacity. The Viral Hepatitis Division funds 46 states, 3 cities, and D.C. To improve local hepatitis B and C care cascades. It's not a lot of funding. It typically goes to fund, you know, about 1 FTE, sometimes less, to do prevention coordination at the state or local level, and they're tasked with a lot with very little, including conducting community planning and capacity building. We're also starting to look at establishment of elimination programs, or at least planning for those. And so just beginning that. And then also related to building state and local capacity, our division conducts a number of EPI-8 investigations. We've been on a couple for the hepatitis A outbreak I mentioned earlier, but also provide assistance for outbreaks in, for example, dialysis clinics for hepatitis C. We do a lot around supporting providers, health systems, and payers. We issue clinical guidelines, many of them actually. You know, I've mentioned the hepatitis C screening guidelines. We also issue guidelines related to hepatitis B screening. We work with the ACIP very, very closely on all the immunization guidelines related to hepatitis A and hepatitis B. And we have guidelines in corrections, and so issue these quite frequently. We also provide syringe service program implementation and training, so getting at that primary prevention. We enable screening and treatment and engagement of people who inject drugs, and we do this through our prevention coordinators and a variety of other projects. And we also provide testing algorithms for clinicians and laboratorians who are often confused with serology testing for hepatitis B and C. Building partnerships, of course, is key. Our partners, we couldn't do anything that we do without our partners. And so, you know, we fund a number of projects through these partners, through interagency agreements or cooperative agreements, but you know, I don't have time today to go into it, but did not want to leave any of our partners out because they're just so important to us. We empower consumers through public education materials. We develop quite a bit. We develop PSAs, patient education fact sheets. There's currently an online risk assessment tool that the general public can go on and answer some questions to find out if they need to be tested. And so, again, it's just very broad strokes on what we're doing. I could talk for days on all the activities that we're engaged in, but I just want to, in summary, just leave you with making sure you understand that hepatocellular carcinoma or liver cancer incidence is rising. Both hepatitis B virus and C virus infections cause many cases of HCC, but not all of them. And HCV, as well as HBV, is largely underdiagnosed. And in the case of hepatitis C, the incidence is rising. But the good news is there are highly, highly effective interventions for both. They're different, but hepatitis B vaccination, you know, if we could get everyone vaccinated, we could eliminate hepatitis B. We also want to prevent transmission of both B and C through harm reduction services. And then for those that already have hepatitis C and have chronic infections, you know, there's really great therapies available. They're still expensive to a degree, and they're coming down. There are many policy restrictions that we need to overcome to make sure everyone has access, but it's quite positive to know that there is an easy treatment that we can cure and use treatment as prevention. So with the capacity to deliver all these interventions, which we might not have quite yet, but we're working towards, I think elimination of these viruses as a public health threat can be achieved, and that's where the National Academies report comes in, and our collaboration with the Division of Cancer Prevention and Control, who helped fund this. But this, you know, was a two-stage report that did focus on the first one was meant to tell us whether elimination could be possible, and the National Academies stated that it was, at least as a public health threat in the United States. And then the second report really came up with recommendations on how we could achieve that. And there's quite a bit we need to do still. We need to improve surveillance both for hepatitis and for liver cancer and hepatocellular carcinoma. I think we could do more at linking the two. And then just improving access to interventions that I've mentioned, the curative therapies for hepatitis C and the hepatitis B vaccine. And then, of course, testing people, identifying them so that people know that they can be treated. So that's all I have.
Thank you so much, Dr. Ryerson. We really appreciate it. We've had a couple of questions come in, but what we're going to do is save those until after Dr. Momin's presentation, and then we will address questions to both of the CDC speakers at that time. So, Dr. Ryerson, if you can pass that little green ball over to Dr. Momin, and then you should have control of the slides now. Thank you.
Thank you, Aubrey. Can you hear me, Aubrey?
Yes, loud and clear.
Great. Well, thank you, Dr. Ryerson, for helping to set the stage by describing the connection between chronic hepatitis B and C viruses and liver cancer. This helps to allow for a smooth transition into the work that we do in our division, the Division of Cancer Prevention and Control in liver cancer, and why this collaboration, as you mentioned, between our division and the Division of Viral Hepatitis at CDC is needed and is important. So I'd like to begin my talk by briefly describing the work of our division, specifically the work of the National Comprehensive Cancer Control Program, and briefly highlight the aims of our division's collaborative study with the Division of Viral Hepatitis, and then end with some promising practices in liver cancer prevention and some of the interventions that our programs have implemented in their respective populations. And I'll also leave you with some next steps and ways in which I feel that programs can help to or can inform future planning. So I don't want to spend too much on this slide. I think Dr. Ryerson did a great job with presenting some of this information, but basically worldwide liver cancer is the second most common cause of cancer death for men and women combined. Recent reports, not only from North America, but Europe and Japan, have shown that the incidence of hepatocellular carcinoma, which is the most common histological type, as Dr. Ryerson mentioned, is increasing. And according to the 2015 annual report to the nation that Dr. Ryerson presented as well, we saw that the death rates for the cancers, for most cancers, declined or were stable from 2003 to 2012 among men and women for each race and ethnic group, with the exception of liver cancer, in which the incidence rates increased for most of the racial and ethnic groups. So the rates, as Dr. Ryerson mentioned, are highest among American Indians and Alaska Natives, as well as Asian Pacific Islanders and Hispanics. Liver cancer incidence rates among U.S. men are more than twice those among U.S. women. And in a recent study using Concord data that I published, the 5-year net survival earlier this last year was for liver cancer is 14.8%. So it does have a very low survival rate. However, chronic hepatitis B virus and hepatitis C virus infection, as well as cirrhosis, all contribute to the risk of HCC, among others. As Dr. Ryerson mentioned, that most cases of HCC are preventable. And so, therefore, there are these methods to reduce the risk of liver cancer, including evidence-based strategies and interventions that specifically relate to the risk associated with hepatitis, it being a major risk factor. And so, therefore, the importance of our division's work with DVH, the Division of Viral Hepatitis, and really helping to fight this disease has been wonderful. Vaccination, as Dr. Ryerson mentioned, against HPV infections for all infants at birth, and then those adults who may be at an increased risk, as well as testing for HCV, and then linking those patients to follow-up care, all leads to this decline in the incidence of hepatocellular carcinoma. So I've included this graphic, this slide in here, which it highlights at a very high level our division's strategic priorities and our aspirations. Our areas of focus are, 1, to eliminate, and in no particular order, but 1, to eliminate preventable cancers, 2, that all people get the right care at the right time, and then 3, focus on cancer survivors and improving their quality of life. So we are engaged in these priorities through our work in addressing health disparities, our collaborations, our partnerships, our work in collecting and analyzing our data, translation of this data, and then evaluation, among many other activities that we're also engaged in. Now, this year, the National Comprehensive Cancer Control Program is celebrating its 20th anniversary. So for 20 years, CDC's cancer program has helped to reduce the burden of cancer in the United States. The national program helps and funds all 50 states, the District of Columbia, 6 U.S. Associated Pacific Islander jurisdictions, as well as Puerto Rico, and 8 tribes or tribal organizations, with the primary focus of creating coalitions, looking at the cancer burden in their specific area, prioritizing the proven strategies for cancer control, and creating cancer plans and putting those plans into action. Now, a little bit on the study, which was funded through the Division's Future Directions Fund, and the Division of Viral Hepatitis came on board as a collaborator and funded one of their programs, the Cherokee Nation Health Service Program. I first want to start off by thanking Dr. Alex Millman for his work in leading the study from the Division of Viral Hepatitis. His expertise and his contributions towards the study have been phenomenal, and I greatly appreciate that. So basically, the purpose of this study was, one, to review current literature and programmatic activities to develop a promising practices manuscript for liver cancer, which right now is currently in CDC clearance, and we're very excited to publish and share this information with the larger community. So this manuscript guided the development of an action plan, which is a work in progress on liver cancer for the National Comprehensive Cancer Control Program. This study also included an implementation phase in which we recruited and brought on 3 programs, 2 of them being the National Comprehensive Cancer Control Program and 1 a Division of Viral Hepatitis program. And these programs implemented various promising practices that were tailored to their specific populations. So the examples of implementation will also be included in the final action plan that is currently a work in progress, and this will help assist with the adoption of liver cancer activities among the larger program, the other comprehensive cancer control programs. Now, the full manuscript is currently in cross-clearance, and it includes key promising practices, as I mentioned, for liver cancer prevention, and we've grouped this in 4 areas based on the National Academies report. So one, and Dr. Ryerson mentioned these 4 as well, the improved surveillance, knowledge and awareness, immunization, and improved viral hepatitis services. So unfortunately, due to time restraints, I will not be able to share the findings from our publication. However, once the paper has been published, we can disseminate this manuscript through various channels. And what I'd like to do, though, in the next few slides is briefly share some examples and interventions from this paper in the next slides that were implemented by our participating programs in this study. So as I mentioned earlier, there were 3 programs that were involved in this study and have done some amazing work in this area. We're currently cleaning up the data sets. We're writing out our closeout reports and in the process of conducting our evaluation. So I can't share the findings, but I at least wanted to share some of the key interventions that were implemented. So first, for Cherokee Nation Health Services, so for its HCV extension for community health care outcomes, or what we call the ECHO telehealth project, Cherokee Nation conducted biweekly virtual clinics, and basically what they did was the hospital's outpatient outlying clinics connected with their central HCV specialist team and their infectious disease specialists at their main hospital's facility. So the purpose of these virtual clinics is for the outlying clinic provider to do case presentations on HCV-infected patients in rural areas. And so each month during one of their 2 virtual clinics, Cherokee Nation dedicated a 15-minute didactic session to educate providers about all known causes of liver cancer. In addition to leading these didactics, these 15-minute didactics, they also assess changes in knowledge and attitudes about liver cancer prevention among those who attend. And so we do have all of the raw data that I mentioned earlier that we're cleaning up, and we'll hope to be able to present some of that data. In addition to the ECHO meetings or the ECHO didactics, they also conducted educational workshops. So they developed slides and presented to provider education workshops regarding liver cancer, specifically surveillance, prevention, and detection. Each of these workshops were approximately 2 hours in length. In addition, they conducted screening tests. So Cherokee Nation purchased 400 OraSure HCV screening kits, which were distributed to a dental clinic, and the clinic had a process in place for detecting or testing and then detecting positive results and engaging those patients or linking those patients to care and medical management treatment. And then lastly, they distributed approximately 2,000 patient education packets to patients with cirrhosis or those that were at risk for developing cirrhosis. As we know, cirrhosis is a precursor of liver cancer. So then we had the Cherokee Nation Comprehensive Cancer Control Program, and so one of their interventions was conducting these community coalition meetings. So they facilitated coalition meetings regarding liver cancer surveillance, prevention, and detection. Each of these meetings lasted approximately 30 minutes in length and was held at various venues, so different venues in different geographic locations. And the reason for that is to ensure that attendance was by different audiences. We also assessed changes in knowledge and attitudes about liver cancer, surveillance, prevention, and detection of those that attended the meeting. As far as print media, so Cherokee Nation Comprehensive Cancer Control Program they distributed about 6,000 trifold brochures within their local communities and clinics. And these brochures basically provided basic health education regarding liver cancer. So what it is, the incidence, prevalence, all known risk factors, symptoms, screening, testing, treatment. Again, tailoring it to their populations. And then lastly, we had the Idaho Comprehensive Cancer Control Program. And they developed and they facilitated a liver cancer prevention and hepatitis B vaccination presentation for healthcare providers. This presentation was offered during their 6 regional booster shot immunization workshops. It was a great collaboration between the Comp Cancer and the immunization program that took place in Idaho. The presentation, as I mentioned, educated healthcare providers specifically on liver cancer prevention and hepatitis B vaccination. They also developed a digital and a print marketing content for liver cancer and hepatitis B vaccination, and that was distributed throughout Idaho, and with the goal of increasing knowledge and awareness of liver cancer amongst Idahoans. And the materials that were developed included a liver cancer infographic. They developed 2 posters that were resized from their infographic, and 10 to 15 social media graphics, a short form video as well. Materials were also distributed at their booster shot immunization workshops and also online via their social media outreach. And I put the link in here. They're also available online via the direct link that's provided on this site. So you have access to all of the materials that were developed from their campaign. Now, I don't have preliminary results yet, as I mentioned, but I can share some of the successes of the project thus far. So there were 8 echo didactics that were conducted, which is really a success. I mean, to develop 8 different sessions specifically on liver cancer was very well received and a great achievement. There were 8 provider education workshops that were developed or delivered. Of the 400 OraSure screening kits, there were 390 that were used. We actually used 10 for training to train the staff. 2,000 patient education packets were disseminated. 7 community coalition meetings were conducted, and 6,000 brochures were disseminated at senior sites. As Dr. Ryerson mentioned, the baby boomers are a high-risk population as well. So there were 6 presentations that were given in Idaho counties to the healthcare providers, a number of products, as I mentioned earlier, from their social media campaign that were developed and shared during their campaign. So lastly, we're wrapping up the project in the next several months, and really our focus now is to finalize and disseminate our promising practices and manuscript. And the final action plan, like I mentioned, is a work in progress, and that's really our 2 immediate resources that we would like to share with the programs. In the meantime, there are ways that we feel that you can begin to inform future planning. I know that year 2, after speaking with our project officers as well, I believe year 2 work plans are complete, so this would help planning for year 3. So we've included some ways that you can inform future planning, and programs could first assess the burden of liver cancer in your population, focus on defining the groups within your population that are at high risk for HCV and HBV infection. I know that there was the initial poll that was conducted, and I think that's helpful to know the various populations that you're working with. And then speak with your local immunization programs and viral hepatitis programs to determine ways that resources can be leveraged and potential partnerships can be undertaken. As we saw with Idaho, with one of our sites, there was a great partnership that was developed. consider adding strategies for HPV vaccination for primary prevention and then HCV screening for secondary prevention in your work plan. And then on our end, at CDC's end and in our division, we're working to incorporate these strategies and many more promising practices from our manuscript into our library of data, indicator and data sources, which we call LIDS, for our program. So again, once this manuscript is published and the action plan developed, I'd be happy to present on those two resources as well and disseminate them.
Wonderful. Thank you so much, Dr. Momin. We really appreciate that. Now we're going to have a quick couple of minutes here for questions and answers. I've got 3 questions that are in the queue. If anyone listening has additional questions, feel free to type them in the Q&A box now. The first question, and I'm not sure, Dr. Ryerson, Dr. Momin, you can sort of decide who answers each of these. The first question is, would we say that hepatitis B treatment prevents liver cancer? Is that how it should be phrased?
Yeah, this is live. Yes, so right. Unlike hepatitis C, there's no effective cure for hepatitis B, but there are important interventions that are available for anyone that has chronic infection, and it's very important that people with chronic hepatitis B infection be monitored regularly by a doctor who is experienced with treating people with hepatitis B, and this medical monitoring. And sometimes when necessary, when you get to a certain degree of cirrhosis, for example, there can be some antiviral medications given to help reduce the liver damage that occurs and ultimately hepatocellular carcinoma. It's also important for these people to be screened regularly, or I don't want to call it screening, but get surveillance for liver cancer with imaging studies so that if they do develop liver cancer, it can be caught early. So right, since even though there's no cure, there are interventions to help protect the liver, to keep it from going into cirrhosis and ultimately liver cancer. So it is very important for these people to be diagnosed and followed by a physician who is familiar with hepatitis B.
Okay, thank you. A second question came in. What data are there around children with chronic hepatitis B diagnosed with cirrhosis and their risk of liver cancer? I don't know the statistics offhand. I can give you some statistics that might not directly answer your question, but when infants and young children are exposed to the hepatitis B virus and get infected, they're much more likely than adults to actually develop chronic infection. So chronic infection will occur among 80 to 90% of infants who are infected. It goes down as the children get older. I think it's about 30% for kids 6 and younger, and then it goes down to between 1 and 12% for older children and adults. And we also know that approximately a quarter of people or infants who get chronic infection as infants will eventually die prematurely of cirrhosis or liver cancer. I don't have information on when, within their age or at what age they might die or be diagnosed. Our surveillance system in viral hepatitis is limited for the chronic infections. So we do get reports of chronic infections, but it's not broken down by age group. So I hope that at least provides a little information for you. Mm-hmm. And then a third question, thank you, a third question that came in. What is CDC doing? You've described kind of what the Division of Viral Hepatitis is doing and what the Cancer Control Branch is doing, but what have the programs done to support capacity in tribal programs, given the disparities in that population?
Yeah, so Vidush, I'll maybe try answering this and pass it to you while I have the mic open at least. As I mentioned, our prevention coordinators in most of the states and a number of cities are working with a variety of partners. I think given the limited resources available to them, we only ask that they identify two kind of key populations, whether that's clinic-based or a specific geographic area, to really focus their intervention efforts currently. But Vinush did mention the Cherokee Nation Elimination Program, and I would say that is really a stellar program that is kind of leading the idea of elimination. They've shown that it's really possible to make great strides in reducing the burden of hepatitis C in the Cherokee Nation, and so we're hoping to use the lessons learned there to expand not only to other tribes and tribal organizations, but really to all populations in the United States. So, Vinush, did you want to add anything to that?
Yeah, no, and I think, so Cherokee Nation, as you mentioned, Dr. Ryerson, is a great example, but I think addressing other strategies, so increasing diversity in the healthcare workforce and building culturally and linguistic competency and understanding of health disparities to improve the prevention practice among minority populations has been a strategy that our programs and with that population has been engaged in. There's a lot of increasing provision of these cancer screening services that are targeted to minority populations and with an emphasis on timely follow-up. I know we mentioned linking them to care, so timely follow-up on abnormal screening results to help improve rates of cancer detection, timely treatment. Yeah, so I think those are the two areas, and again, the ones that I mentioned earlier when I spoke about Cherokee Nation, which is a great example of some of the interventions that they're working in.
Oh, great, thank you. And I'm sure other CDC-funded tribal programs can hopefully learn from the results coming out of Cherokee Nation. One final question, and then we're going to move on to some of the strategies recommended by the National Academies. Could you restate what the current infant birth dose vaccination is in the U.S.? The questioner was under the impression that these days birth dose vaccination was near 100% in hospitals. What was the statistic you provided for hepatitis B?
Yes. Can you? I can't get off mute. Can you hear me?
Yes, we can hear you.
Oh, now, okay. I'm sorry. It was, so the percentage of children aged 19 to 35 months who received the hepatitis B vaccine within 3 days of birth in 2015 was 72.4%.
Okay. Okay. Thank you. And then I think actually, because I'm looking ahead at my slides, I think, yeah, okay. And then for full immunization, the National Academies report states 90% of children in the U.S. are fully immunized against hepatitis B. That was 2013 statistics. So not quite 100% to the person who asked that question.
Right, and I'll say the birth dose since 2013 have actually gone down. So the statistic I cited, the 72.4% in 2015, that same statistic was 74.2, confusing, 74.2 in 2013. So it's gone down to 72.4.
Okay, so we need to be paying even more attention to promoting vaccination.
Absolutely, and I did. I had a little image on one of my slides, but I failed to mention it. But last year we published for the first time a national progress report for viral hepatitis, and that's where the statistic is coming from. And it is a measure that we are monitoring regularly. We have a goal of reaching 85% coverage for the birth dose by 2020. So exactly, we're going in the wrong direction.
Okay, good to know. Thank you for the person who asked that question. Okay, so that's all the questions we have that have come in so far. If you think of other questions, please feel free to submit those and we'll address those in a moment. I am going to move us ahead. We're going to talk about the recommended strategies for addressing hepatitis B and C viruses to reduce new cases of liver cancer. And why are we doing this on May 16th? May is Hepatitis Awareness Month, if you weren't aware, and National Hepatitis Testing Day is May 19th. So that's why we're hosting this webinar now, to help raise awareness and encourage you to leverage this Awareness Month to also share this information locally. I wanted to mention, I posted a link in the chat box for where we will post the PDF of today's webinar slides. If you want to refer back to them, get any of the links that we share today, and the archive video will also be there. But this webinar is special and different from our usual webinars because we're going to provide a similar slide deck that is a PowerPoint file, complete with a script and comments for trainers, so that you can then take the PowerPoint file and present it confidently in coalition meetings, task force meetings, raising awareness and educating providers in your community, community members. So that PowerPoint is also going to be available for download today, and we hope that you find it useful. As Blythe mentioned, there was this National Academies report that came out, and it had several essential strategies that are relevant to cancer control. And so we're going to summarize those today, and we're going to talk about resources to advance each of those strategies and potential partnerships that you can pursue to help you be successful. If you haven't looked lately at your state, tribe, or jurisdiction cancer control plan to see if there are goals or objectives around hepatitis, now would be a great time to do that. Here's an example back from 2012 from Texas, and they address increasing vaccination for vaccines shown to reduce the risk of cancer, and they mention both the hepatitis B vaccine and human papillomavirus, or HPV. So if your plan does not mention hepatitis, working with your cancer control program at your Department of Health and with your local comprehensive cancer control coalition would be a great place to start acting on the National Academy report recommendations. So GW worked with CDC's Division of Cancer Prevention and Control and the Division of Viral Hepatitis to synthesize the most important and actionable interventions outlined in this landmark report from the National Academies for things that you can do as cancer control or viral hepatitis professionals and partners. And they include these 5 themes: improving access to HPV vaccination, increasing knowledge and awareness of viral hepatitis in the community, increasing knowledge and awareness of viral hepatitis among healthcare providers, especially that connection with liver cancer, and then improving delivery of viral hepatitis services and conducting disease surveillance. So you'll notice that several of these focus on policy systems or environmental change, and that would then lead to broad sustainable impact. And so we're going to go through each of these one by one. We have about 20 minutes left, so I'm going to kind of rush through this. But as I mentioned, we will provide the PowerPoint file that has the full script and all of the links and resources that you need. So we already talked about the need to improve access to hepatitis B vaccination. That's the first theme here, and the strategy that the National Academies report discusses is working with partners to expand access to free vaccinations in pharmacies and other easily accessible settings, including HIV or STD clinics and community health centers. These locations are convenient. They may have evening or weekend hours that do not require appointments. And so this is an essential intervention that you have an opportunity to promote in your local jurisdiction. Here are a couple of resources that we would recommend taking a look at in order to act on this intervention. I think there's a lot that we can learn from what's been done in human papillomavirus vaccination and the strategies that have been undertaken to increase access to those vaccines, including facilitating HPV vaccination in venues outside of the medical homes, such as pharmacies, health departments, urgent care centers. The report that is linked here talks about ways that states can enact laws to implement policies that allow pharmacists to administer vaccines, because in some places there are restrictions on what vaccines are offered in pharmacies. And this is a really good opportunity for comprehensive cancer control to work towards policy and system change by partnering with professional organizations such as the American Pharmacists Association. This NACHO report that's linked here is also a useful guide with tools and resources to help local health departments implement programs to increase hepatitis vaccination and how to collect, report, and analyze data. And so it includes model practices that you can then share with clinics locally. Here are some suggested partners. As I already mentioned, the American Pharmacists Association, partnering with local pharmacies and pharmacists. And then, in addition, the National Academies report recommends working with the criminal justice system to screen and vaccinate against hepatitis B in correctional facilities, following regular clinical practice guidelines. People who are incarcerated often live in close quarters, making immunization more important to prevent transmission. And we'll talk more specifically about criminal justice system partners under the Improving Delivery of Viral Hepatitis Services section. The second theme in the National Academies report is increasing knowledge and awareness of viral hepatitis in the community. Despite the strong link between viral hepatitis and liver cancer, many individuals may not know about hepatitis B or C virus, and chronic infections are lifelong, and they can be clinically silent in most patients. And about 2/3 of people infected with hepatitis B and half of those infected with hepatitis C virus are unaware of their condition. So it's really important to increase awareness of viral hepatitis in the community. And the essential intervention promoted in the National Academies report is to use tools such as CDC's viral hepatitis risk assessment and share that in the community. The link is here on your screen. And this tool is a 5-minute risk assessment. It can be taken online or printed and administered by paper, and it generates a personalized report that determines if a person should be vaccinated and or tested for viral hepatitis. Here are some resources to help you raise awareness in the community. CDC has put a lot of formative research and creative development time into these communication campaigns. I encourage you to use these links, go to their website, see all of the materials that they provide, free and downloadable fact sheets, posters, templates, public service announcements, and the No More Hepatitis campaign is targeted at reaching baby boomers and healthcare providers to encourage hepatitis testing, and then the No Hepatitis B campaign is to increase awareness about the epidemic among people who may be infected with hepatitis B, and has materials in English and many other languages. So that's really helpful. You don't have to do any development on your own. That's all there for you. Some other tools that are available from other organizations, GW has a viral hepatitis and liver cancer social media toolkit with pre-written tweets and Facebook messages and information about social media best practices. Prevent Cancer Foundation, the Association of Asian Pacific Community Health Organizations, Hep B United, and the Association of State and Territorial Health Officials all have toolkits and resources for how to do policy advocacy, media outreach, how to host a successful screening event, and how to communicate about screening and testing and raise awareness in the community. So I would encourage you to take a look at all of these resources. Some partners you might want to consider when increasing knowledge and awareness in the community include faith-based communities and organizations, college campuses, local media, and really leveraging the awareness-raising campaigns to get the message out there and get people to pay attention. So again, May is Hepatitis Awareness Month. World Hepatitis Day is in July. And Liver Cancer Awareness Month is October. So you've got, 3 different time points in the year that you can use to talk about this public health issue. The third theme that we're going to talk about is increasing knowledge and awareness among healthcare providers. According to the National Academies report, one of the main bottlenecks in hepatitis care is the need for patients to be treated by specialists. As a result, viral hepatitis care remains out of reach for people in rural and underserved communities. Primary care is an efficient way to provide services, but if a patient develops cirrhosis, management becomes more complicated, as patients may need frequent hospitalization. Because treating viral hepatitis carries these risks, providers in small practices may be reluctant to accept patients, causing a disparity where viral hepatitis care is out of reach for people in rural and underserved communities. So what can we do about that? There are 2 interventions here that the National Academies recommended. First is engaging, training, and educating healthcare providers and systems to prevent, detect, and treat viral hepatitis. And the second is promoting healthcare professional resources, such as the HBV and HCV clinical guidelines and fact sheets. Cancer control coalitions and the Hepatitis Task Force and other partners can play a central role in engaging and training providers, promoting these resources locally to clinics and other organizations, professional membership organizations. And this document here is called the ABCs of Hepatitis, and it provides an overview of the clinical guidelines, the tests for infections, vaccination recommendations, and treatment options, all on this one-pager, and so it's a really handy document to share with healthcare providers. We created this brand new 2-pager, and I would encourage you to click on the link on the slide and download it. With this document, this is a summary of the National Academies report, and it summarizes the strategies to reduce viral hepatitis-associated liver cancer. On the right of the screen, you'll see the back page of the document, and this is everything we're talking about today on the webinar, all of the 5 themes and interventions under them. But the front page is a good baseline kind of overview of the connection between liver cancer and viral hepatitis and what some of the statistics are, some of the key information that healthcare providers, the general public, policymakers might not be aware of. So you could use this tool to increase awareness generally about viral hepatitis and liver cancer, but also to help secure funding to build partnerships around the specific strategies that are recommended. Another resource that we created in partnership with the Cancer Control Branch and the Division of Viral Hepatitis at CDC are state and a national profile about liver cancer. And it doesn't look like my slide animation is working. This is the bottom half of the fact sheet. And this, again, talks about what you can do to address viral hepatitis and liver cancer through surveillance, vaccination, screening, treatment, and policy systems and environmental changes. But the top half of the document that unfortunately is not showing up on this slide right now provides data on viral hepatitis infection prevalence and liver cancer rates in your state. So we've created one of these with the most recent data for every state in the U.S., and then there's also one that is a national fact sheet that just is a general overview providing the national level data, but not the state-specific data. And again, you can use these profiles to educate policymakers, decision makers in particular. I think this would help you have the right talking points to prioritize and raise awareness. But you can also take this to talk to healthcare providers in your jurisdiction to get them to really focus on the issues around viral hepatitis and liver cancer. Some other resources to raise awareness among healthcare providers come from ASTO, from CDC. CDC provides tools for health professionals, including fact sheets and guidelines, and training resources available at no cost, and with continuing education credits so that they can get up to speed on the recommendations around vaccination, screening, diagnosis, and treatment. I think Banush mentioned earlier Project ECHO. This is an interesting model where primary care providers can learn to provide high-quality viral hepatitis care without having to have a specialist on site, and this is done through kind of distance learning and training. So you can read more about that from the University of New Mexico. And some key partnerships that you might want to think about when raising awareness among healthcare providers include professional organizations. The University of Washington has trainings for healthcare providers that you can promote. The American Association for the Study of Liver Diseases and Infectious Diseases Society of America may have additional insight on healthcare professional resources and development opportunities. So I would encourage you to explore those potential partners if you're looking to increase awareness among providers. The fourth theme that we're going to cover is improving delivery of viral hepatitis services. I won't go through all of these statistics, but I do think it's important to note that incarcerated populations bear a disproportionate burden of viral hepatitis. And so they're one of the key populations that you might want to consider if that's not a population, or if the criminal justice system is not a partner that you're currently working with, then that's definitely something you might want to explore. And then the National Academies report talks about how treating everyone with hepatitis C, regardless of disease stage, would avert considerable suffering in patients. It would also protect society by reducing the population reservoir of infection. So there are a number of interventions that the National Academies report promotes here, and we're going to go through them kind of quickly. But the first is to collaborate with local, state, and federal corrections departments to reach incarcerated populations who are at this increased risk, promoting screening, management, and treatment clinical guidelines, and developing referral systems out to social support and physical and mental health programs so that the patients can be treated for the underlying substance abuse problem or other issues that need to be addressed. Some resources to do this, there are examples of working with criminal justice systems that have been successful that we can learn from. Here, there are some here that you could explore. CDC has a correctional health webpage, and these others here have specific examples of what has worked. Some of the other things that you can do include supporting and coordinating with community research efforts, such as those that serve key populations and aim to alleviate stigma or promote health among incarcerated populations, so community research efforts, and then working with public and private health plans to lift restrictions and lower costs of treatment therapies. These are both important barriers currently, and things that coalitions and task forces can work to break down. Some resources to do that. GW has an example of how the DC community worked to advance and improve access to care for Medicaid patients through a policy change. So that might be one example of how you could work with local payers to improve access to screening and treatment for underserved populations locally. The American Liver Foundation has financial assistance resources. And then NASTAD has information about pharmaceutical company patient assistance programs, and these are just some resources that can help increase access and mitigate the cost of treatment. Additional things that you should think about doing include promoting guidelines for screening, management, and treatment among pregnant women to prevent mother-to-child transmission for hepatitis B, and promoting harm reduction strategies. One of the presenters mentioned needle exchange programs. That's one example of a harm reduction strategy that addresses the underlying substance use disorder. Referrals to opioid agonist therapy, counseling, testing, those are other examples of harm reduction. There are a lot of resources out here on these strategies, and they're not all specific to hepatitis, but CDC has several web pages that are useful. There's also the North American Syringe Exchange Network has a directory of syringe exchange programs, and they may have resources that would help you consider how you might go about getting a syringe exchange program in your area if you're in one of those red pockets that Dr. Ryerson showed that doesn't currently have a syringe exchange program. Again, partners in improving delivery of viral hepatitis services include state and local detention centers and correctional facilities. There's a National Institute of Corrections at the federal level. Local universities and state governments, local agencies that are conducting research, you can help support community research to improve surveillance and knowledge about effectiveness of strategies. CDC has the National Prevention Information Network and other, as mentioned, local syringe services programs. If you have a service program, you could reach out to them and see, how you could be helpful in supporting their work. The fifth and final theme that we're going to talk about is conducting disease surveillance. And I think based on the information that the CDC speakers presented and the questions that the audience had, there's still room to track progress towards elimination of these viruses, identifying spikes in new infections, getting better insight into some of the patterns of the diseases, the access to care, estimating prevalence, and tailoring the prevention response and programs, using these evidence to develop our programs. So there is a national notifiable disease surveillance system that you or your partners can use to get data to identify trends, inform patterns, and describe the burden in your local community. These data might already be included in your comprehensive cancer control plan for your state or jurisdiction. You can also support state-level collection of hepatitis B and C virus data in the viral hepatitis surveillance program so that these data are available for future program planning. There are guidelines for viral hepatitis surveillance and case management that CDC has. You can promote those, share those locally. ASTO has viral hepatitis epidemiologic profiles that you can look at, and the Association of Immunization Managers has an adult immunization resource guide that you can disseminate locally. There is a chapter in that resource guide that highlights Idaho, Iowa, and Michigan's activities, their successes and their challenges in using the immunization information system for vaccine preventable diseases. So you can learn from their lessons in implementing your own surveillance. How about partners in surveillance? There are several CDC-funded programs for hepatitis prevention and surveillance. The second bullet here are specific points of contact in each state that's funded by CDC for viral hepatitis prevention. So you can reach out to them, see what they're doing, get them connected to your work. And then some of these other programs were mentioned by the speakers earlier. So that is a very, very quick overview of the strategies, the 5 main strategies that are recommended by the National Academies to reduce hepatitis B and C viruses to reduce the burden of liver cancer. I know I covered that quickly and didn't get to go into all of the details, but I do want to be respectful of your time. So I want to promote a couple more resources. If you are thinking about taking what you've learned today back to a coalition meeting or a work group or a task force to do some planning around what you can do to choose any of these interventions and maybe just start with working on one, there's a worksheet that we've developed that helps you think through what your organization can do and who you might need to collaborate with to accomplish that. And so you can download that at the link here. As I mentioned, we'll provide a PDF of today's slides, and we'll also provide a PowerPoint file that you can use. It has a script, and you can take that back to your coalition and present it and share this information to raise awareness. So with that, I would like to ask just a quick question, one more poll. Of the 5 themes that I presented of essential interventions, which do you think your organization is most interested or most ready to implement? Please go ahead and take a few seconds to answer that poll. Okay, so it looks like people are most ready to work on B and C, increasing knowledge and awareness in the community and among healthcare providers. But some folks are looking at working on vaccination and delivery services as well, so that's great. Thank you for indulging us in that. Here's our contact information. If you need technical assistance or want to reach out, please feel free to do so. And with that, we have some closing polls for our webinar evaluation. If you would be so kind as to complete those, we would really appreciate it. It helps us improve for future webinars. Thank you again for your time today, and please come back to our website, that link I shared for the archived webinar, the slides, they will all be posted there. So thank you again for your time today, and have a great day. Thanks to our speakers, Dr. Ryerson, Dr. Mohlman, thank you for your presentations.